All right, we're going to go ahead and get started. Good afternoon, everybody, and welcome. Welcome to the Chronic Disease Prevention Council's Heart and Disease World Stroke Day stroke series. Wow, that's a lot of words. So we are so excited to have you here with us. The stroke series is a 4-week program of lunch and learns. So kind of really little quick snippets on prevention, education, and awareness. That's all going to lead us up to World Stroke Day. We are so excited. We have a really dynamic program for you to kind of come in at your lunch hour and get some quick information and education and some resources to continue on with the amazing work that you're doing in our program. So our presenters are going to be presenting, and we'll have quick Q&As afterwards. So you can definitely, during the Q&As, come off mute, and then also put questions in the chat box. We'll be monitoring that as well. So we're going to go ahead and get started with our first. Oh, great. Yes, please. Laura, do you want to go ahead and start the first slide? And so we can start off with our introductions of our first presenters. All right. Yes. Thank you. Our first presenter, very good, is Sam Melada. And he is, if you want to show the second slide real quick for me. There we go. He is an amazing individual who has lots of experience educating and raising awareness for strokes in our community and nationally. He is a nurse educator and a clinical education at UNM Hospital, a trainer of neurosciences nurses in the ICU, progressive care, and outpatient settings, certified neuroscience registered nurse, stroke certified registered nurse, and linguistics PhD candidate at UNM. So I am very honored to welcome him to our virtual stage. Sam?
Thank you very much. It was a very kind introduction. Let me pull my screen up here. So what I'm going to be talking for, I could talk for hours about any of these topics that we're going to be talking about today. Can everybody see my screen okay? Yes? Okay. So what I'm going to be talking about is primary stroke prevention today. We'll later on have some discussion of secondary stroke prevention with one of our neurologists here from UNMH. But I wanted to start off with, how do we stop the first, how do we prevent the first stroke from happening? And when I think about an ounce of prevention being worth a pound of cure, I was curious about how much a pound of Ben Franklin's would be. Did the math, and that comes out to about $45,300 if you want to know what a pound of $100 bills actually amounts to. While I am kind of joking in there a little bit, the importance and the possibility of preventing stroke is the cost of stroke, the economic burden of stroke on society and on hospital systems and on the United States and the world is immense. So prevention is really the key, and it's really something that I'm going to try to cover thoroughly, but kind of give you some simple takeaways. If we know how strokes can happen, what is our primary prevention strategy? What are the ways in which we can look, what do we look to? We look at risk factors. Now, what I want to start with is some numbers. These are general numbers across the United States. We call this region here in the South, in addition to calling it the Bible Belt for some people, we also call it the stroke belt. This is statistics from 2017 to 2019 for adults 35 and up. This is stroke mortality. And if you look at, and this is everybody ages 35 and up, but if you look at white non-Hispanic adults 35 and up by county, looks a little bit similar. If we then look at African-American population, 35 and up, you can see it's really focused down in that area. But for here in New Mexico, where we have a huge Hispanic population, it's important to look at the numbers. This is Hispanic adults ages 35 and up. So statistics are interesting when you piece them, take them apart. I think this is a helpful place to start when we think about our community and we start looking at risk factors. So we have modifiable and non-modifiable risk factors for any, when we're talking about disease prevention. Non-modifiable things, we're all going to get old, right? We just keep getting older and older. Can't modify that yet. Gender, race and ethnicity, and then hereditary factors. What kind of role does age play as a risk factor? It doubles with each decade after you turn 55. But lately, these are American Heart Association, American Stroke Association numbers. There's been a 44% increase in hospitalizations in that age range between 24 to 44. And a lot of this is attributed to the rise in high cholesterol, obesity, and type 2 diabetes in children and young adults. Another reason why we see strokes here at UNMH, hemorrhagic strokes, which I'll talk about in a little bit, is also the use of sympathomimetic drugs, use of cocaine, use of methamphetamines, which of course we have a significant problem with that here in Albuquerque and in the country at large. It is interesting to see that there's about a 30% decrease in the ages 65 to 84, and this is attributed to better control of those risk factors. So as people age and they're making more frequent trips, hopefully they have access to healthcare, making more frequent trips to the doctor. I know for my own parents who are 88 and 91, my dad can tell you what his INR is. He can tell you all his lab values. They keep track of their blood pressure. And that's part of the reason why they've made it to 88 and 91. So age is our first non-modifiable risk factor. Gender, this is interesting. I saw Jessica's got some slides to talk about this a little bit more because there's a lot of misunderstandings about stroke and gender. The incidence of stroke is significantly lower in women that are younger and middle-aged, but after 55, it starts to pick up. So the end numbers kind of get skewed a little bit, but more women die from stroke, and about 55,000 more women a year, I think was the last number I saw. I don't know when that was tallied. Another factor, low birth weight. This risk is more than double for babies that are below that 5 pound, 8 ounce weight, birth weight. And then with genetics, this is a whole other thing that we could talk about forever, but to give you some idea about genetic problems that lead to stroke, sickle cell, Marfan syndrome, other types of coagulopathies, problems with your blood clotting, either not clotting or being hyper coagulable. And then family history, right? That kind of sets you up for increased risk. But let's hold on to that thought about family history. As far as race and ethnicity, African Americans have the highest incidence of stroke, more than any other group. Females that are either Hispanic or African American, greater than 70 years old, have a much higher risk of stroke than white females. The interesting thing is the difference is not as apparent in males. It's not as clear. It's not clear cut. And there's a lot of reasons for that that are kind of beyond the scope of a quick discussion. 50% of Hispanic men and 40% of Hispanic women have these underlying conditions as well that contribute to stroke risk. And then Native American population and the non-Hispanic white population have similar rates as far as the race ethnicity, but there's other factors that we have to consider related to diet and other things that happen with economically challenged populations. So these numbers are not as clear cut as it would seem. So what are our modifiable risk factors, right? These are the things that we all want to work on. High blood pressure I put first here because it is the #1 risk factor. If you want to take one or two things away from what I'm talking about today, high blood pressure is the #1 risk factor for all types of stroke. And as we look, at these images here, I kind of think during COVIDs and people got glued to their TV sets, stayed home. I started to feel like this guy, watching TV, though I don't smoke. I did manage to quit smoking. 2 years cigarette free. But just putting on a little bit of weight. We'll get there. I'm sorry, I'm getting ahead of myself. So high blood pressure, that's our #1 risk factor for all types of stroke. Diabetes is a risk factor. High cholesterol, cardiac disease, especially atrial fibrillation. You have risks of clots forming in the heart and then the heart throwing those clots upstairs. And they travel very easily. It's a very straightforward path going from the heart to the brain, unfortunately. So AFib, being able to control that and control your blood coagulability is super important in terms of being able to prevent stroke. Smoking. These ones that are highlighted, I'm going to kind of give you as the 5 takeaway ones, and I'll tell you why in a minute. Physical inactivity. We all can use, try to get our steps in and do a little bit more. It doesn't really take that much. I'll give you some concrete numbers when we start talking about how do we approach these modifiable risk factors. Obesity, and we'll define what that means in a sec. Alcohol use. Alcohol use is significantly related statistically, especially excessive alcohol use, to stroke. I used to like to just read the articles that tell you that red wine with dinner is good for you, but then there's a lot of other research out there that says otherwise. But as a former food and wine writer, I was like, oh, look, yes, wine is good. Yes, especially the red kind. Oral contraceptives. This is something that I think we've done a better job overall in helping people understand the risk. Young women who use oral contraception, and particularly who are smokers, that puts you at double the risk, or at least increases your risk factors by 2, I should say. Hormone therapy, which if you think about in terms of what oral contraceptives do, and postmenopausal hormone therapy also puts you at risk for the same reasons that oral contraceptives do. Diet. You see these things that are highlighted. These are a little more approachable. Estrogen deficiency, sympathomimetic drugs, as I said, these are stimulants. These are people who use cocaine, people who use methamphetamines. This puts you at significant higher risk of stroke, particularly hemorrhagic stroke. Most of the young people I ever cared for in the years that I was at the bedside here at UNMH, the majority of people under age 30 that I took care of that had strokes were young men who had substance use disorders. Alcohol abuse, pregnancy, antithrombotic therapy. Obviously, we want to protect your blood clotting. Keep your numbers within a certain range, but like for instance, my father has very thin blood because of his cardiac issues, but if he falls, he's at risk for a bleed. He's also, if he doesn't manage his blood pressure, he's at risk for stroke. So we don't want to do away with antithrombotic therapy, but we want to be able to manage it safely, manage blood pressure and other things safely, because it does put you at risk having thin blood. So anybody want to hazard a guess? You can put it in the chat. What of these non-modifiable risk factors increases the risk of stroke by 30%, but patients can still benefit from prevention? If anybody wants to throw something in the chat. I see smoking, but smoking is not a non-modifiable. Yes, who did it? Jessica Richardson comes through. Family history is a non-modifiable risk factor. But patients can still benefit. So I don't want you to feel like non-modifiable risk factors it's not something that's just doomed. You're doomed to have a stroke, right? Family history. As long as we know that you have a family history, then we can intervene and we can provide preventative measures that will help to manage those risks. I'll close this. Okay. So 5 factors account for up to 90% of ischemic and hemorrhagic strokes. Okay. I could talk a lot about the difference between the two and what causes each and what the treatment course is and all that. But if we just want to talk about stroke in general, ischemic and hemorrhagic stroke, there's 5 factors that contribute for that account for up to 90% of all strokes. Again, number 1 is high blood pressure. Can't stress that enough. 2 is smoking. 3 is physical inactivity. 4 is an unhealthy diet. Now, I'm glad we have somebody who's going to talk about nutrition because obviously that's beyond the scope of me talking today. And then we'll talk about what a high body mass index means. But I can give you at least something to hopefully we can sort of dovetail this together. So when we're talking about high blood pressure, what does high blood pressure mean? Borderline hypertension, the medical definition is 120 to 129 systolic over 80 diastolic. So we tend to think about 120 over 80, right? What's our primary prevention there? Making some lifestyle changes, losing some weight, having a healthy low sodium diet, and then much, much more than that as far as nutrition goes. And just a little bit of physical activity. Now, if somebody's already at that stage, a lot of people walk around with hypertension, don't know that they're hypertensive, and somebody's got high blood pressure in the 130 to 139 over 80 to 90, then we're going to start medication along with lifestyle changes and try and target that blood pressure below 130 over 80. If somebody's at stage 2, we're going to be a little more aggressive with medication and lifestyle changes. But this is these are manageable ways of separating out what does high blood pressure mean and what are the risks associated and what are the things that we can effectively treat it with. Smoking, I laugh when I see these things that say how to quit smoking because it took me years to quit smoking. You don't just sort of like, you know what, today I'm just going to quit smoking today. That's it. I'm done. It took a lot. There's some people respond well to medication. The things that you see advertised on TV, different, medications that people take, there's at least 3 or 4 of them. Some people do really well. I can tell you the medication didn't work for me. I don't know what ultimately made it happen. I think probably my kid and thinking about all the secondhand smoke that I breathed when I was little. And lowering my stress level significantly. But quitting smoking is something that we never want to, don't quit quitting. Physical inactivity. What does this mean? What does moderate to vigorous activity mean as it's defined? Well, here in America, the AHA, ASA, the recommendation is 40 minutes a day, 3 to 4 days a week. In Canada, they divide it up as 30 minutes a day, 5 days a week, right? In the UK, they talk about it as 150 minutes per week. So however you want to break it up, I think any of these will work, depending on what works for your schedule. If you're thinking about what you want to recommend to your people that you take care of, what you want to recommend, what you want to do for yourself. If you're looking at this like, oh man, I'm at risk for stroke. I've got these stroke risks. These are reasonable numbers that are measurable. Now, an unhealthy diet. I'm going to leave it to Jessica to talk about dietary things, but things, low sodium diets, Mediterranean diet. The main thing is reducing sodium intake related to blood pressure, but also cholesterol, all these other things that put you at risk, diabetes, hypertension, and high cholesterol all put you at risk for stroke. But this is something that's modifiable. And lastly, body mass index, right? And what is this? We hear this, right? We hear BMI. Overweight BMI is considered 25 to 29. Obese is 30 to 39. And then morbid obesity is greater than 40. It is important to consider that, BMI is a measure of something, but it doesn't measure or separate out things like bone mass. Arnold Schwarzenegger, I would wonder what his BMI is. I don't know how tall he is or how much he weighs, but his BMI would be skewed, right? Today, I did a little calculation in preparation for today. My BMI is 27.34. So I am overweight according to this. And I think that's probably accurate because I don't fit into the same clothes that I wore before the pandemic that I, used to be able to wear those. And now I had to buy some new clothes. But I'm 5'9" and I weigh about 180 pounds to give you some perspective. So hopefully that gives you a sense of, what BMI means and the limitations, but there is something to be said. The way that it's calculated is, your weight in kilograms divided by your height in meters squared. So at least it gives you some sense, but bodies come in all different shapes and sizes, and it's not something to completely hang your hat on. So what I would like to, okay, we're at 20 minutes. I would like to open it up for questions if anybody has any questions. I know that was very brief. I could talk about these things for hours, but hopefully that gives you a sense of 5 factors that you can take away. Questions from folks out there?
If anyone has any questions, you don't need to you can go ahead and pop off mute to do it. You don't need to type them in the chat.
I do have one question. I know you mentioned smoking increases your risk of developing a stroke. Has there been any research on specifically smoking cannabis, and is there any correlation between that and like increased risk of stroke now that legalization has become a thing in New Mexico?
That is a really interesting question. I have not seen the research on that. But you know what? I'd always take notes when I give presentations, and I want to look that up because I know that while people that are proponents of cannabis, whether it's oral or smoking or whatever, say, oh, it's really good for anxiety, it's good for stress. THC raises your blood pressure, like in the acute stage, the same way that alcohol does. When you drink, as you drink, your blood pressure goes up. You might feel relaxed, which might lead you to believe that you're like, oh yes, I'm relaxed. This is good for me. But smoking or oral use of THC does drive blood pressure up. So, but does it drive it up enough to really put you in a risky space? Does it drive it up like cocaine or methamphetamines? No, but it does raise your blood pressure while you're under the influence. So I'm going to have to look that up. It does not have the same overall systemic effect that tobacco does, though. So I would guess that the risk is lower, but I'm just guessing. But really great question.
I had a question for you.
Mm-hmm.
So what about if you were younger and you were taking oral contraceptives and you were like smoking, but all of that's done now and you stopped all of that? How's your risk looking today?
Your risk does go down once you stop taking oral contraception, but I don't know what the duration of time is. It's one of those things it's more rapid than, say, when people quit smoking, your risk of lung cancer, you return to baseline after a certain number of years. This is much faster as far as once your natural hormones return to regular state. Now, depending on the age that you stop taking contraception, right? Because you're also at risk in perimenopausal women are at risk for stroke because of coagulopathies related to hormone changes. But if you're, say, in your 30s and you stop taking oral contraception and quit smoking, your risk would drop rather rapidly.
I just wanted to comment if that's okay. I put it in the chat, but I'm not sure if everyone saw it. There are also hormone therapies for gender identity or gender transitions, and that does also increase the risk as well.
Absolutely. There is a whole, with our trans population, there's a whole cluster of things, unfortunately, working against, increasing their stroke risk, I should say. It's not an intentional state of things entirely, but it's just, hormones as well as access to healthcare really puts them in they've got a special category of risk. I'm glad you brought that up. Thank you for bringing that up, Jessica.
And someone had a question in the chat, Evelyn, does a prior heart attack make it more likely to have a stroke? And that's what happened to someone in her family. Can you speak on heart issues a little bit more?
It could, because anytime you have impaired cardiac function, but particularly what we think of is, so there's two types of ischemic strokes. You either have a clot, you have blood slowly getting cut off because we have plaques building up, and we call that a thrombotic stroke. But then we have a lot of different things that can happen with cardiogenic, what we call originating. Cardiogenic means originating from the heart. Cardiogenic embolic strokes, where an embolism develops in the heart and then gets thrown up into the brain. So anytime that there's damage to the heart, it could put you at risk depending on the type of damage, valve damage to the valve, infection, as well as development of AFib post heart attack, if that makes sense.
And Sam, as we transition,
yeah,
as an educator, and you have so much experience with that, with different audiences, what do you think is the best way that, this organization, but also there are so many people from so many different walks of life on this call, what can they do to help build this education about this issue in the community?
That's a big question. I think, we started raising awareness just by having people be aware of FAST, right? Face, arms, speech, time to call 911, and then starting to have billboards and starting to get people to think overall that we know what a heart attack's like. We know from the days of Fred Sanford, for those of you that are old enough in the audience, clutching at his chest and saying, "Oh, this is the big one." We all know what the signs of a heart attack are, right? But getting people to start to understand what the signs of a stroke are, and then also understanding that it's something you need to act on quickly, it really is going to take a variety of, whether it's posters on the wall in the hospital, billboards on I-25. There's even, just to give you an amazing outside the box thought, to make it short, one of the best stroke prevention projects I saw in the African American community was medical professionals went in and trained hairdressers to pass on stroke information, stroke risks, how to modify your modifiable risk factors, so that when you go to get your hair done, you've got a captive audience right there, and you've got somebody that they might trust more than some stuffy guy in a white lab coat. And I thought that was a brilliant, there's always new ways to think about how to reach the community, and that one in particular was really amazing. As far as what a great idea to get somebody that's a trusted person in the community's life to do their hair and talk to them about stroke at the same time. And they did before and after, pre-test, post-test type stuff. So, there's so many different ways that I don't know where everyone's background is on the call. And it was kind of hard in figuring out, I didn't want to use too much technical speak in this. Putting things out in plain language, explaining things in simple terms that are easily grasped. One of the things that people wonder why I'm doing linguistics, I'm looking at health literacy, and particularly in anti-vaccination rhetoric, but in other fields as well. And there's a never-ending opportunity to improve health literacy and improve our outreach.
Well, that was amazing. I want to thank you, Sam, as
You're
always,
welcome.
for being amazing. And if you have more questions, which you probably do, I think you could still go ahead and put it in the chat, and we'll make sure that we get them to Sam and the team and get your questions answered. I'm going
and feel free, if anybody wants to email me or call, I put my contact information if you want further, if you have other stuff you want to ask about. Okay.
Awesome. Thank you. Are you going to stick around, Sam?
Yes.
Okay, perfect. So I'm Jessica Richardson. I'm a professor here and a speech language pathologist at the University of New Mexico. I direct a lab here with the UNM Brain Scouts, and also the Stable and Progressive Aphasia Center. So we have space teams and space camps and all kinds of things having to do with space. I'm also the outreach director for the Center for Brain Recovery and Repair. Really trying to do a lot in the community to raise awareness about rehabilitation after various brain injuries. I'm just going to do 7 quick minutes of myth busting that will complement what Sam just chatted about, and reinforce, I think, some of the really important points that he was making. And then I'm going to pass it over to someone to talk about a great nutrition and food resource here that we have in the community. So here is our 7 minutes of myth busting. So hold on to your lunch in one hand and your chair in the other, because we're going to go really fast. So the myth: stroke is only a problem for older people. So Sam covered this a little bit, of course, too. But the fact is that on average, about 38% of people who have a stroke are younger than the age of 65. And minority populations have a higher percentage of strokes in younger people as well. So there are some people who are even more at risk for younger strokes. This has had, many implications. This means that we don't have enough research related to young stroke, return to work and stroke, sex and intimacy and stroke, parenting and stroke. We don't have enough supports for young stroke as well. So the fact that we're not paying enough attention to this fact has led to some, really big deficiencies and gaps in our support in our communities, not just here, but everywhere. And this is getting worse. And so Sam also mentioned this. I'm just going to show you a picture to really highlight it. This is actually showing what he was talking about, where people who are 65 years and older, where their total percent over time of their stroke incidence here in New Mexico has improved. So that means that, there's less strokes happening and less people dying from strokes in this older group, as you can see. When you start getting in the blue colors, for the most part in New Mexico, that means that these areas are improving in terms of decreasing the stroke incidence and stroke deaths. There are still, of course, some hot spots that you can see by the light red to the dark red. We have a really dark red up in the northwest corner. But when you switch this, if you'll look to what I've circled up here, when you switch this, the 35 to 64 years, and you can even do more exploration and look specifically at gender as well, you can see it's not such a rosy story anymore, or actually it is rosy, right, in terms of the red, and that over time, the percent change has gotten worse for this younger age group. And so, I don't say that to scare you, but I say that to just make sure that I bring it to your attention and to help you bring it to the attention of people in your community. All right, another myth, just to reinforce: men are more likely to have a stroke than women. The fact is that women are more likely to have a stroke and die from stroke than men. It's the number 3 cause of death in women, and women die from stroke at 2 times the rate that they die of breast cancer. So, of course, I really appreciate all of the campaigns that are out there for breast cancer. It's on everyone's mind. The NFL wears pink, all types of awareness, but there's not that same amount of awareness for something that kills people at 2 times the rate. And so just bringing that fact to you to help you bring it to others. Stroke signs are the same for everyone. That's the myth. The fact is that stroke may present differently for many people, and signs are known to differ in women. And so what I'd like to do really quickly is to show a very brief video that is free and available to you, that is showing the signs, an expansion of what Sam mentioned, the FAST. We're going to talk about Be Fast, and then a little bit of information about how it's slightly different in women. So how do I recognize a stroke? To recognize a stroke, be fast. B is for balance. Look for sudden changes in balance or coordination, or sudden dizziness. E is for eyes. Look for sudden trouble seeing out of one or both eyes. F is for face. Look for sudden facial weakness. Part of the face may seem to be drooping. The smile may be uneven. A is for arms. Look for sudden change in arm mobility or strength. S is for speech and language. Look for impaired speech, whether talking or listening. This can include slurred speech, nonsense words, or difficulty repeating simple phrases. T is for time. Time is brain. Immediately call 911. In addition to be fast, be aware that symptoms often differ for women. These symptoms may include nausea or vomiting, seizures, hiccups, trouble breathing, pain, fainting or loss of consciousness, and general weakness. It is important to be aware of the symptoms for women so that their treatment is not delayed. All right, and I have put the link to this in the chat. And a quick other myth, let me move that chat out of the way. And Sam brought this up as well. I love how much our minds were in tune. If you don't live in the stroke belt, you're not at risk. The fact is that the stroke belt doesn't mean exactly what we think it means, and you can still be at risk. And so the information that he showed you, which I also have highlighted in this video here, is that what we typically think of as the stroke belt, when you look at it through a different lens, and specifically looking at some minority populations, Hispanic, Latino populations, you kind of get a flipping here. And I'm just going to fast forward just for time, and I'll of course send this link so you can kind of catch this towards the end. Replicated here. You see similar stroke belt patterns for Black Americans in older adults and in younger adults. However, you see movement of the stroke belt westward when you look at rates for older Hispanic Americans and younger Hispanic Americans. Because of the forced removal and relocation of Native Americans more westward, it is expected that the stroke belt for Native Americans would not be positioned in the southeast, but would be more central and westward also. Okay. So those were the myth busting, super quick myth busting. I can take questions at the very end, but right now I would like to turn it over to Jessica O, who is joining us today. Even though she's not feeling too great, she's powering through a recent injury to give us some very important information. She's the Health and Wellness Initiative Manager at the Roadrunner Food Bank of New Mexico. She's been there since 2018. She does a lot of partnering and collaborating with various New Mexico healthcare systems. Also, she honorably serves as a council member to the New Mexico Primary Care Council, the board director to the Health Equity Council, lots of really important positions in the community. And last year, she also co-chairs the cross-sector heart disease and stroke prevention meeting with the American Heart Association, as convened through this group here, the New Mexico CDPC. So without further ado, I think I'm going to turn it over to Jessica O. I'm Jessica R. And I believe Laurel is going to drive the slides. So someone else will be showing those slides.
Well, thank you so much, Jessica, for the introduction, and thank you, Sam, for your illuminating presentation. I know I have some questions. I'll probably be emailing you this week on some things. And so, as Sam had mentioned in his presentation, that certainly diet is a preventative measure. And of course, Roadrunner Food Bank is in the work and the effort and the service to support community members who are food and nutrition insecure. We're going to focus on a little bit today is the health and wellness initiative at Roadrunner Food Bank, which I oversee, which is really the arm of programming that works with the healthcare delivery system and working with community members who are managing nutrition-related chronic health conditions, such as all cardiovascular diseases and diabetes and many other kinds of conditions, and also being food and nutrition insecure. Does somebody have the slides?
I
Thank you, Laurel,
apologize.
for.
I'm having technical difficulties, but we'll pull them up in 1 second. Hang on.
Okay, I appreciate that,
It's
Laurel.
freezing, so hang on real quick, but you can keep going. Sorry about that.
Oh, no worries. While Laurel's bringing up the slides here, thank you. I'll talk a little bit about, and of course, this was a significantly big topic last week. The White House had its conference on hunger, nutrition, and health last Wednesday. It was an all-day event and affair, and it was the first conference since 1969 under former President Nixon in having this conference. And Roadrunner Food Bank and gosh, there was just so many different organizations, healthcare organizations and food banks and all different kinds of programs. A lot of food is medicine type of programs and produce prescription programs were present at that conference, and we'll talk a little bit about that in this presentation. You want to advance to the next slide? Thank you, Laurel. All right, this is just an introductory slide. Shelby Catrice, who's the Community Nutrition's Program Manager at Roadrunner Food Bank, she was intending on co-presenting with me today, but unfortunately she has a family emergency that came up this week and couldn't attend this presentation. And then, of course, myself as part of the Health and Wellness Initiative. You want to go to the next slide? So Roadrunner Food Bank's mission is to provide nourishing food to New Mexicans through vibrant community partnerships and passionate public and private support. Now, some of you may have seen presentations about Roadrunner Food Bank or through Roadrunner Food Bank in the past, and maybe have remembered a slightly different mission to Roadrunner Food Bank. We just have finalized our strategic planning, and we've done some revisions to our mission statement at Roadrunner Food Bank. And this is the new mission statement that I think we're trying out at this stage. So let us know how you like it. Next slide. So how do food banks work? This is just a very simple infographic on how food banks have been really conducting their service in communities across the United States since at least the 60s and 70s. There's some food banks that are a little bit older than that. And they really were in the position to rescue food that was being wasted. That was really kind of the principal heart of food banks. Millions of pounds of food are wasted, and food banks rescue it, or it's donated to food banks to provide to community members. Roadrunner Food Bank just is the warehousing and sort of the rescuing and receiving the donations, and we provide it to food distribution partners who then serve it to communities. And we have about 500 member agencies throughout the state of New Mexico, and we're serving about 70,000 individuals a week in the state of New Mexico. Next slide. This is just a little area or a map of our service area. Roadrunner Food Bank works with 4 sister food banks. One in the light green on the eastern part of the state is serving those 5 different counties. The Food Depot in Santa Fe serves about 9 different counties, and then we have sister food banks that are serving San Juan, McKinley, and Cibola counties on the western part. But overall, we are serving the entire state of New Mexico. Next slide. All right, the Health and Wellness Initiative at Roadrunner Food Bank really got underway back in 2014, 2015, and Roadrunner Food Bank is about 42, 43 years of age. So the Health and Wellness Initiative is really kind of the newer arm of programming at Roadrunner. But the mission is, in partnership with health-focused organizations, we provide access to healthy foods and educational opportunities that encourage wellness within communities. If you want to flip to the next slide, we'll talk a little bit about our vision. We too believe food is medicine. Our vision is to equally nurture the wellness of communities and individual members by being an integral partner in the healthcare system, advocating for broad-based health system change, and supporting the safety net with health goals. I will mention I was really very pleased and affirmed last week at the White House conference. I attended virtually for that conference, and one of the pillars in that conference was integrating health and nutrition. And there's a fantastic panel of physicians who were talking about chronic health conditions, such as heart disease and diabetes and hypertension, all the things that Sam and Jessica have mentioned. And they really affirm that community-based organizations that are in this intersection of addressing health and health equity and health-related social needs or structural determinants of health, all these community-based organizations are indeed and in fact a part of healthcare. Next slide, please. So what does it cost our healthcare system when a person experiences food insecurity? Back in 2016, 2017, Feeding America, along with several other organizations, developed a report called State Level and County Level Estimates of Healthcare Costs Associated with Food Insecurity. And it was really driven by Dr. Hilary Seligman through the University of California in San Francisco. She does so many different things within our nation. But she developed a really good tool for food banks, as well as a lot of healthcare organizations, to measure that impact on what it costs healthcare when somebody is food insecure. And nationally, it was a $52.9 billion in healthcare costs were associated with food insecurity for adults and children, which is a staggering amount. And that report was able to break it down by county level and community level. And in the state of New Mexico, that was an additional $1,834 in excess healthcare costs for a person facing food insecurity annually. Now, I always look at that number, and I know that as we're serving community members who are coming to us, they need help. There's a lot of stressors going on in their household, and it may be medical issues, it may be managing chronic health conditions, it may be that there's other health-related social needs, as well as economic issues going on in the household. And an extra $1,800 a year is a significant aspect to really contributing towards financial toxicity for individuals who are struggling so much already. So that number always is staggering to me as well. Next slide, please. So the White House Conference on Hunger, Nutrition, and Health. Now, what I've taken here is just a snippet from the National Strategy Report. It is about 50 to 60 pages long. I'm up to page 10. As Jessica mentioned, I've been kind of nursing a little bit of a shoulder or back injury that's been kind of paining me. So I'm a little bit behind in reading this report, but there's some really good recommendations that have been developed in this national strategy document. And the call to action in the pillar titled Integrate Health and Nutrition, and this may appear a little bit small, really had some really very good suggestions. And if anybody is interested, I'm happy to get the National Strategy Report to everyone, if that's something that you're interested in taking a look at. But there's a lot of call to action to expand coverage of food as medicine interventions across the United States, that states should collaborate with nonprofit and community-based organizations on produce prescriptions, as well as integrate nutrition experts into their health departments and modernize the scope of practice laws, as well as providing or expanding coverage of nutrition services, including produce prescriptions and our medically tailored meals for target populations. That was a big one in one of the panels that I had attended, as well as many other aspects. And the national strategy document really was trying to take a look at what are the impacts of food insecurity and diet-related diseases, and those individual and societal costs. Certainly at the food bank level, particularly within the health and wellness initiative programs, we see a significant number of individuals who are referred to our programs that are really struggling to afford their medications, to afford seeing their medical providers, afford healthier foods, particularly if they are trying to manage a cardiovascular disease and they need diets that are lower sodium, and or they have other conditions that they're managing. Healthier foods are definitely far more costly. So there's a lot of things that we've been trying to remedy through the Health and Wellness Initiative. Next slide. And I may have overdone it on the slides because, like Jessica and Sam, like I'm always very eager to talk about these topics and could talk for hours. So I think what we're going to do is we're going to just skip probably the next 3 slides, Laurel. I think Jessica and Sam have given us a lot of data about stroke and other factors within New Mexico. I want to make sure we get everybody out of here on time. All right. Thank you, Laurel. So this is just talking about the Health and Wellness Initiative partnership opportunities at Roadrunner Food Bank. And it's segregated or organized in two different categories. One that are Roadrunner Food Bank led distributions, and the other side that's healthcare led distributions. But what I want to point out here is that there's many different interventions and partnerships that we offer to the healthcare delivery system or to health focused organizations that are really tailored to what that healthcare organization is potentially looking for. And I want to draw attention to the column in gray on the right hand side. We are just starting to begin medically tailored foods or medically friendly food distributions and boxes. So we're piloting this right now, but we've come up with a heart healthy food box, as well as a diabetic friendly food box, along with having food boxes that are vegan and vegetarian and gluten friendly and different aspects. And I anticipate that over the next 3 to 5 years, this will certainly grow, particularly in alignment with a lot of recommendations to that White House conference. On the left-hand side is the Healthy Food Center. That is our hallmark program through the Health and Wellness Initiative. And that is a medical referral distribution at our home office that has been in existence since 2015. And we're typically serving about 300 to 400 community members a month. Next slide, please. All programs within the Community Initiatives Department at Roadrunner Food Bank, this is the programs area, are getting more aligned in getting more fruits, vegetables, fresh product, and health-focused food items, as we're trying to be very sensitive to the different needs of communities, the requests of community members, and a lot of the health and disease kinds of conditions that are happening across the state and are unique to each community. Next slide. So I'm going to go through these pretty quickly here so we can wrap it up. If you want to flip to the next slide, this is just the health and wellness goals within the Community Initiatives Department at Roadrunner Food Bank. We are adapting what we're calling a nutrition framework within the food bank. As you recall, in the earlier part of the presentation, I talked about how a lot of food is rescued or donated to Roadrunner Food Bank, and that's really kind of been the work or the business of food banks. But we also know that a lot of that food that comes to us that is rescued, donated, isn't the healthiest. It isn't always the best kinds of foods that are really trying to support community members who are managing nutrition-related chronic health conditions. So we are working on building a nutrition framework that affects all levels within the organization, from our food procurement and acquisition to our financial areas, to the program evaluation areas. And this is quite a big project, but it also means that having more health-focused, nutritious, healthier foods and nutrition engagements may mean that as a food bank, we may be purchasing a little bit more product than actually receiving donation and rescued food. Next slide. We are also working on infusing health and nutrition best practices throughout Albuquerque, modeled on the Healthy Food Center. Once we get this piloted, then we're looking at getting this in other communities throughout New Mexico. Next slide. And Lastly, one of the big goals that we have is really finding a way to tether together our childhood hunger initiative, senior hunger initiative, and the health and wellness initiative, and really looking at that impact of providing and addressing food and nutrition insecurity in a more preventative measure starting from childhood. As we know, a lot of community members are accessing food and nutrition support through the food bank, through food distribution partners throughout their lifespan. And as Sam and Jessica had mentioned, that we know, of course, we age, and throughout our lifespan, there's different health things that we're coming in contact, or health conditions that we're coming in contact with as we age. Next slide. And I think we're maybe winding down to our last slides here, but we do have, just wanted to mention that we do have a nutrition education toolkit for partner agencies. And that is to help food distribution agencies really infuse and offer nutrition engagement for the community members that they are serving. Next slide. Certainly, please feel free to reach out to Shelby and I. This is our contact information if you have any questions, need any support, or would like to discuss the White House conference. I love talking about that. I could talk about that all day long, but certainly feel free to reach out to me.
Thank you very much.
Thank you. Sorry, I'm dealing with an unstable internet connection. So absolutely. Oh, yep. I'll pop the link in there. So thank you so much, Jessica, and the work that Roadrunner Food Bank is doing to bridge the gap between food and nutrition security in our community. And thank you, Sam, amazing presentation, and Dr. Richardson, thank you so much for sharing all of your knowledge and information. I will add the extra link. Be sure to sign up for sessions 2, 3, and 4. Special note that session 3 will actually be on a Thursday, week 3rd, but we would love to see you continue this conversation, continue our learning journey as we support our community to address stroke and its effects on the families and the individuals. So thank you so much. And please feel free to reach out with any questions that we didn't answer. Love to do that, be able to answer anything. So I think at that point, I am signing off. Laurel, are we good?
We're good. That was fantastic. Thank you, everyone, for your contribution.
Thanks, everyone, for
having you.
attending. Bye-bye.
Bye.
Bye, everyone.